Next talk, Dr. Meena Chakrabarti will be presenting on diabetic vitrectomies, proliferative diabetic retinopathy with tractional retinal detachment and vitreous hemorrhage. Over to you, Dr. Meena.
There are a lot of things that we know about diabetic vitrectomy, the primary indications for this procedure, the basic principles of membrane surgery, the choice of tamponade agents, and some of the relevant postoperative complications. And there are some things which are new, which includes the use of intraoperative OCT, heads-up surgery, the ever-expanding indications for vitrectomy, and use of adjuvants to enhance the final results of vitrectomy. So my patient is a 46-year-old male. He is a chronic diabetic of 15 years diabetic age with poor diabetic control. He is a hypertensive, but fortunately has a normal renal status. He has already undergone 2 sittings of pan-retinal photocoagulation and 1 anti-VEGF injection, and the duration of his defective vision cannot really be pinpointed. It could have been for years. Why did I choose a surgical option for this patient? Because of his poor vision, and he had a dense carpet of preretinal membranes, underlying which was a total shallow retinal detachment, and he had a stable lasered fellow eye. This is a preoperative fundus appearance of the patient of the right eye and the fellow left eye. He underwent a thorough preoperative assessment, which included both ocular and systemic. There is no point in doing a 2.5 hour long vitrectomy in a patient who has a poor renal status and whose lifespan is very short. As with most of us, my technique is also to underpromise and overdeliver. The do's and don'ts of silicone oil tamponade, the need for positioning in the postoperative period, the need for subsequent cataract surgery and silicone oil removal. A preoperative biometry was done. A suboptimal vision through silicone oil was conveyed again and again to the patient. Emphasis on diabetic control. And we underscored the need for periodic evaluation to evaluate for progression of the disease, and he was also told about the compliance to postoperative follow-up. So this is a surgical technique. I thought I would add a little color to it by giving it a voiceover and music. Membrane dissection is one of the major components of a complicated diabetic vitrectomy. A variety of techniques such as delamination, segmentation, and en-bloc excision have been used to clear the retinal surface of proliferating membranes. This video demonstrates how a combination of maneuvers can be employed to dissect an extensive and adherent membrane in a 46-year-old chronic diabetic with advanced proliferative diabetic retinopathy. The membrane dissection is started inferiorly after excising all vitreous attachments to the edges of the fibrovascular proliferation. A 23-gauge knife spatula is used to sever the vascular nails anchoring the fibrovascular proliferation to the underlying retina. When the membrane has loosened sufficiently, it is segmented with a 23-gauge cutter. The presence of vitreous and additional membranes are most common in diabetic retinopathy. In the nasal quadrant, the additional membrane is excised and the fibrovascular proliferation is peeled away from the optic disc. Dissection is resumed in the supratemporal area. After excision of all loose membranes, using a blunt spatula, an area of cleavage is identified and the 23-gauge cutter is used to segment the membrane into 2 halves.
The lower half is dealt with first. The upper half is segmented into smaller areas and two densely adherent bits are left behind. Perfluorocarbon liquid is used to iron out the retina, followed by N2 laser pan-retinal photocoagulation, a perfluorocarbon liquid silicon oil exchange, thereby stabilizing the retinopathy process. The fundus picture taken on postoperative day 15 shows a stable and attached retina and a significant visual recovery.
So this patient did have a significant visual recovery under silicone oil with a hyperopic correction. His postoperative care included zealous use of topical steroids, mydriatics, and cyclopedic. We did our best to prevent anterior segment reaction, post-vitrectomy fibrin, and posterior synechiae formation. He was cautioned on the need for postoperative positioning, and the duration of positioning was shortened of the first week of the postoperative period. A control of intraocular pressure was meticulously adhered to. The schedule of follow-up for this patient was every weekly for the first 1 month and every 2 monthly silicone oil removal. So he did well with follow-up, and at each visit his best corrected visual acuity, tonometry, slit lamp examination, everything was done. At 3 months down the lane, he developed a significant, about 3+ nuclear sclerosis and a posterior subcapsular cataract, where we did a combined phaco-IOL silicone oil removal. His best corrected visual acuity post-operatively was 6/18 and IOP was maintained at 16 millimeters of mercury. The follow-up still continued. We looked for recurrence of the fibrovascular tissue from the anterior hyaloid, post-vitrectomy glaucoma, neovascularization, etc. And in the process, he developed the open-angle stage of neovascular glaucoma. His pressures were poorly controlled with anti-glaucoma medications. His best corrected visual acuity dropped from 6/18 to 5/60, and his IOP was 40. I did an Ahmed valve implantation at 4 months post-silicone oil removal with intravitreal bevacizumab. Thus, you can make out a small bubble of silicone oil happily resting on the valve, on the tube of the valve. This is his last follow-up picture. He is doing quite well. And let me not let go of this opportunity to canvass for my husband. Please support Arup in his endeavor. He is standing for the post of Vice President of the AIS election in 2024. I thank you very much for your patient hearing.